And thank you for joining us for today's session. We would like to welcome you to this installment of our webinar series that has been aimed at supporting the countries in the sub-region as you update your pandemic preparedness and response plans for respiratory viruses. Through this series, we really aim to provide a collaborative platform for the countries to develop your drafts and to also strengthen that sub-regional cooperation in this particular process. A reminder that each one of these sessions in the webinar series will focus on one of the 5 key components of the PRET initiative. And today we'll be focusing on 2 critical areas, meaning clinical care and public health and social measures. These components are very essential for ensuring an effective response to respiratory pathogen pandemics. So for the section on clinical care, today we are joined by Angel Rodriguez, our advisor for clinical management of infectious hazards at the IHM team. And Angel will guide us through the key clinical management strategies essential for pandemic preparedness. For the public health and social measures section, Evelyn Balcells our consultant for preparedness for pandemic of respiratory pathogens. She will share some insights on the role of non-pharmaceutical interventions in reducing transmission and protecting vulnerable populations. Throughout the session, we really encourage you to actively participate, whether it's sharing your thoughts in the chat box and asking questions during our Q&A section. We would like to keep the Q&As for after the presentations. So at this point, I will hand over to Angel to start the section on clinical care.
Thank you, Ornella. Good morning, colleagues. It's a pleasure to be here with you on behalf of the Infectious Hazards Management Unit. I think you're seeing my screen and you hear me well, okay? As Cornella explained, today we are going to touch base in the clinical care component of the PRET. The outline of this presentation is here, okay? I'm going to start immediately with the background. Here is only a sample or a snapshot about 3 countries in the Caribbean, about the components describing the PRET, and based on that, the inclusion or not inclusion of the component in the updated plan. For example, in Belize, the plan updated in 2011, it's very noted that all 4 components of the clinical care plan are mentioned and described. And it's not that the case in the other 2 countries that only the case management block is described and fulfilled, okay? Sorry if you're going to start seeing some message on the Teams. Okay, so this is important because clinical care includes clinical management, health services, IPC, and basically saving lives. So it's really a critical component and more in the beginning of a pandemic, okay? When, as you previously mentioned, sorry again, okay, let me try to, okay. So as you know, and you remember, in the last 2 pandemics, recent pandemics, H1N1 2009 and COVID 2019, okay, we face in a situation like it's very no or little information about the virus itself, meaning in transmission, in severity, and also the impact. So when the country responds to this threat of this pandemic that is different, affecting different countries, because it's not start in countries at the same time, and specifically in the Caribbean, that is sometimes island that are remote, okay? The waves of the inclusion of the register of the first cases are delayed. So this kind of advantage of also or not, as we saw in the previous pandemic. But the important message here is like you are seeing the screen, like how clinicians, public health leaders, etc., countries are responding with a very little information and a big uncertainty about this threat, the virus itself, and need to respond to prevention control measures. Okay, and this is just to show you how is the process of evidence specifically for clinical care in the provision of treatment. Remember, like the treatment antivirals in this case that we're talking about, virus is the first line because at this moment there is no vaccine available. The other is all the measures for prevention and control, IPC, etc., etc. So this it's important to know the process, but also more important is to include this in the plan for the legislation, because sometimes ethical decisions and interventions and made based on a lot of uncertainty and not the best quality of evidence. Okay, of course this involves a lot of collaborations at global level at different institutional professionals. This is the second one about like what we learn. Okay, so I remember, and I think Dr. Marion is here. Remember when we do this pandemic plans workshop in Jamaica, in Montego Bay, and she explained very nice a presentation, like saying like planning is everything. Okay, but we need to plan based, like this with lessons learned as these reports, like looking forward, but taking a bunch of this evidence during the COVID, in specifically this component, it was a lot of documents and a lot of guidelines that were updated and still updated, and living guideline and resources like the health readiness checklist. These resources that are here for you are important because are still valid to assess the leadership, the coordination, the infrastructure of the health services, the lab, not only the lab for reference lab like national influenza centers or other, but the clinical lab as well, all the management of the bodies, the incineration, the PPEs, etc., etc., etc. So all these documents specifically are talking about the lesson learned about this. And of course, there are not specifically for the context that you deal with in the Caribbean, like small population, not too much, reference hospitals or outpatient clinics, and also with a small population. Okay, but it's important to really use it in these centers, and do this planning and this readiness assessment in a daily basis. Okay, and I'm putting these resources because it's important also to train the clinical professionals in the human resources based on this, because if the new pandemic appears in next year, the most common pathogen will be a virus, a respiratory virus origin. And the guideline that is really recommending all the evidence principles to treat these patients independently of the region is the one that you're seeing here, the toolkit for clinical care that was adapted during the COVID and also was used at the beginning for treat the patients and save lives. Includes, of course, early identification, triage, IPC measures, the distribution, bed capacity, organization of healthcare services, oxygen management, etc., etc., etc. And the other two that are very important are the two in the middle, the blue one and the orange, about the antivirals. The antivirals right now are available for specifically influenza and SARS-CoV-2. And when the beginning of pandemic, a new threat for influenza, specifically, for example, starts, we are going to use oseltamivir for sure, a recommendation on baloxavir, because it still have sensitivity. Okay, so these results are for you, are important to look back and then apply this in your plans. Of course, The plans and recommendation following the PRET initiative have very specific recommendations to update your plans, but basically need to be very operative. You can put a lot of annexes here or following your hospital guidelines as a reference, not necessary to have a big plan, but most important is to test as well. Okay, the next slide is specifically for the component of health service provision. And this information is based on the checklist that also is available for you, and I think you know pretty well. And the component of clinical governance is pretty important because you need to adapt your plans based on your healthcare system structure, public and private, okay, and have these mechanisms for normative and legislation pre the emergency in peace times to use and have agreements, for example, with insurance companies. Okay, I remember also with the and you as well, the COVID pandemic, that hotels were used for isolation. You know, when it was this strategy for contention, stop transmission, and also this also is important to use it as a bed capacity itself. Okay, so this is very important. The specificity of diagnostics, and I'm sure you also are going to review this in the community surveillance aspects, but here is to really ensure the access to rapid tests, okay, with the legislation for these pathogens, okay, that at the beginning, again, are not validated, but if there is soon point of care tests available, validated, recommended by organization, you need to have all the mechanisms in place, okay, to receive even a donation that also need to have a legislation for that, or purchases and have the agreements with the laboratories, because the important here is to have real early diagnostic of the patient and have a decision to treat with some antivirals or other interventions that are needed. Okay. The alternative care models, and it is very important, is about not only for the emergency itself, it's also for the other diseases that need to be diverted to other systems or treat like virtually, etc., etc., etc. Okay, that is important also to manage all this surge capacity, define what will be the hospitals to the reference, etc. And also again, the human resources, okay, is key in this process. And I have example also as well, like the pediatrician in COVID, it was more adults cases than children. So the pediatrician was surge capacity to treat adults patients, but this training need to be before, okay? And in case of influenza, is basically all the ages, okay? Surge planning is pretty important about basically dividing the outpatients situation, like the severe, non-severe, mild cases managed there, and also have a specific triage and capacity to define critical areas in the hospital to manage a lot of capacity, specifically in the capital cities. Okay, that is when the reference hospitals are there. Okay. Resource mapping is important to really distribute, because you need to also remember, like, the epidemics, outbreaks, pandemics, etc., occur in different areas in the country, not at the same time. So it's important to have the mapping of the resources available, including ventilators, for example, and then human resources again, and other aspects that can be use it of rapid response teams, especially teams can also support other areas that are facing things like that. I remember specifically, for example, in Ecuador, Latin American country, that it was like the focus, like in Guayaquil specifically, not other areas, or here in the US, in New York, for example. Okay. Research is pretty important here, but I think the recommendation here is to really use it like a regional capacity, because it's really not the priority for healthcare provide search treatment to conduct research, but it's important to assess really with this uncertainty, as I explained before, what we are facing of that, okay, what on this, and this is like unity studies and other blueprint, etc., that can support like a region, different countries, 6, 8 countries with defined hospitals to do this for to redefine the strategy and strengthen the prevention and control aspects. Okay, this is key. And need not to be delayed, because I'm doing a lot of examples for COVID because it's very recent and I think it impact a lot our region, but we really don't know to have information of COVID until the virus was imported to Europe, specifically in Italy. Okay, so that's also that's important, and this is related with this specific slide that is assessing the severity. Okay, the real severity of the disease is, of course, genomic surveillance. That is an innovation of this pandemic, but not only for virologic, also epidemiological genomics that need to be also maintained for this and be part of assess this severity of the patients, but to know really the case fatality rate, the specific lethality, and the transmissibility, because it's different, like the H1N1 that was more mild, that a COVID at the beginning that was kind of severe, but later with Omicron, but different, okay? And that impacts that use of treatments, the allocation of services, the surge capacity, etc. Not necessarily a virus that is with a lot of severity is worse than one with a lot of transmissibility. Remember Omicron variant that impact a lot of health services to manage these patients that were mild, okay, but collapse the healthcare services. That's what is very important. And here is key, because these studies are based on the SARI established platforms for sentinel surveillance, etc. But during a pandemic, this system need to be really expand to have the more information available for the healthcare services, and give data and provide data not only for your country but also for the region and the world, and assess this. But these need to be really tested in peacetime, but also have the agreements with institutions like universities, hospitals, etc., private sector, etc. But these need to be signed before. Okay, these aspects. The IPC component is critical. Again, you have here the elements and the guidelines are there about the necessity to have a core national IPC program, okay, in your country. Okay, and there is like the checklist for this program, and more important, okay, there's a course that is for respiratory protection of healthcare workers, because there is two things here. One is to prevent and control the infection, but also is to protect your healthcare workers. Okay, that means that you have to in stock all the PPE necessary, in peace times, and ready to use, like the seasonal virus season. Okay, and then have the rotatory stock, because during the pandemic, like the providers are you remember clearly the situation, specifically in the Caribbean, is even worse because it's the island. No, it was no flies, and the companies that sell this was sell it and buy it by other countries with more resources, etc. So really, this is key to have this stock, have the legislation, have the resources, have allocation of the budget, have a place to storage this in the proper conditions, etc., and manage this stock and using it based on the standard and contact precautions. Is key, and is part of IPC program, is the training. According, I have a very task force for this and search capacity. And the next one is an example of the precautions that you are going to use, yes, if a novel respiratory infection appears. This is There's two reference here, and new guidelines also for syndromic screening for IPC with the PPE needs. And also we have estimation based on a scenario like the COVID, previous COVID or influenza as well. And this table is coming from the protocol for the response and investigation on this. Basically, standard precautions, contact precautions, and airborne precautions, okay? This is for the treatment and management of case. But remember, the IPC, PPE also need to be during the triage with the admin people that is not clinician or a nurse are in contact with patient, need to have all the PPE components, also the disinfection, like to wash the hands, etc., etc. All these things need to be really evaluated, have it in place, and that's why are the readiness checklists that you need to use it and include in your plans. Okay, I know that this is a lot of information. I need to be digest, not in this, and I think I have 6 more minutes in this short presentation. But the important here is to recognize like the key components for the early response of the emergency, okay? The infrastructure needed, the human resources, and also all the procedures. The next one is about antivirals specifically, not necessarily other components that are pretty important, like vaccines, etc., etc. In this case, but not only include antivirals, include other medicines that are necessary to the support and treatment of the patient that need to be in place in the pharmacies of the hospitals and review this stock, like corticosteroids, for example, like liquids, all these things. Okay, specifically in antivirals, I put this slide to give you a key message. Okay, I know that the majority of you here are PIP countries that receive partnership contributions. Others no, not receive direct partnership contribution, but also are a part of the PIP regional component. Okay, and this PIP plan component specifically have pre-pandemic agreements with suppliers, donation for influenza antivirals like baloxavir, like oseltamivir, okay? And this is a good example at global, regional level that need to be replicated in your countries to have this pre-pandemic agreement, to have also emergency use regulatory pathways, stockpiles, and okay, based on risk and severity. And the best way to use this and treat is during seasonal respiratory outbreaks. Okay, and I mean there is a guidelines of for this, and you can use it not only for the treatment of severe cases, also for prophylaxis. And here is a very important link with your lab, reference lab, that is like the be monitoring of the susceptibility and the resistance as well. That can be achieved very quick during these situations for that. The checklist for antiviral access is there. I really encourage you to review the ones that we are recommending for COVID, for example, and for influenza, and start doing these actions. It's very important, and that like these antivirals are not, the majority are not as listed as WHO emergency medical list, okay, but are included in the PAHO strategic fund for purchase that allows you to have a better price in a sense. Okay, of course, as I mentioned before, these antivirals, medicines, intervention, etc., change very rapid during a pandemic, and need to be adapted and use it based on evidence, not necessarily with recommendations, for other that are validated, because there is a lot of ethics involved, and also there is the adverse events for these aspects. Okay, and I think this is my pre-final. slide about health services. Okay, here specifically took time to describe more about clinical management of the patient and IPC, that is core capacities for response in the IHR, but also, and this is a lesson learned from the COVID, is to prepare to maintain the essential health services for other disease. Okay, like for example, measles, yellow fever, no, etc., etc. Other things, chronic disease, surgeries, origin, etc. So this guideline that is available that include a lot of checklists and need assessment needs, strategic planning, service adaptation, and indicators to the response, because the life continues. Okay, it's not only the pandemic, it's not only the emergency, the other disease continues as well, and need to be need to be treated and managed with the other patients, for the society more and these critical situations. Okay, and this is one message here. The other message is about like your health services capacity and search capacity. There need to be a map, I think, based on the last pandemic. How was your bed occupancy rate? How was your search capacity? And have these scenarios and have the resources to increase or decrease, etc., etc. Other important things, as mentioned before, is the healthcare workers need to protect the health of these healthcare workers, nurses, admin people, clinicians, etc., etc., and have these indicators as well for absenteeism, because it's not only the provider, it's also the families of these providers that are exposed to this and the virus, etc., etc. In a respiratory pathogen threat, the oxygen is key. There is a guideline again from the emergency department about the evaluation and inventory readiness for oxygen supply. Okay, critical patients, mainly in ICU, require a lot of oxygen, and also like invasive, not invasive, need to be managed and prioritized and have it in stock. And have a really a specialty for this in these scenarios, because sometimes, depending of the outbreak of the pandemic, also these hospitals, mobile hospitals are in place and need to have the technology, the structure to deploy this, including, of course, IPC measures, okay, that are about like the outbreaks. I think that's my last slide. This is a key message about like planning is a really it's a continuation. It's not a one-time thing that you need to do like, okay, I update the plan, here is the plan. No, need to be real plan, need to be test. Okay, and the best way to test is not simulation, is the real seasons. Okay, because patients, every season occurs, severe ones. Okay, and we have a lot of threats for respiratory disease. There is a lot of guidelines available that you can use. Also, there is a lot of tools for assessment and readiness, and based on that, analyze gaps. Okay, and if you do not do like after action review in your hospitals for the COVID, do it. It is really a good recommendation. And more important, innovation need to be maintained and sustained based on resources, of course, but take advantage of global clinical platforms and also integration of systems, because the information that the clinicians are going to provide at the beginning in the clinical history are critical for the response, and will inform a lot of other aspects of the pandemic response. Okay, do a lot of all the working in networks, national networks, subnational networks, regional networks is very important. So in peacetime, need to be foster this collaboration and have ready. If you maybe next April is going to have a new virus, okay, be ready for that, and always monitor and evaluate. Okay, there is in the PRED there is two indicators that are evaluated. That is the participation in WHO clinical platform. If you are familiar with, we can work with that. If not, I can provide all the information. For example, for avian influenza. Okay, the other is the updated or the pressure of national guidance for the clinical management of these severe acute infections. That's the PRED indicators. But the more important, I think, is like the SPAR and IHR core capacity 4 that includes case management and IPC that is important to really evaluate. Okay, happy to support with the unit all this readiness assessment if needed, and thank you very much for your time. Over. This is colleagues we have this network for SARI clinicians in Latin America and also the Caribbean, and thank you for all your cooperation as well. Okay, thank you.
Thank you so much, Angel, for that comprehensive presentation on clinical care. You definitely provided a thorough overview of the critical components required for the effective clinical management during respiratory pathogen outbreaks. As we move forward with updating these national pandemic preparedness and response plans, I think it is very important to remember that PRET promotes the development of plans that address all respiratory pathogens, so not any one specific threat. Many of these systems and capacities that we might put in place, they they will apply across a variety of pathogens. But I think for key components like clinical care, it is crucial to develop pathogen-specific annexes, especially for the diagnostic and treatment protocols. These annexes can ensure that each of our plans are adaptable, but also very precise and ready to address unique characteristics of the different respiratory pathogens that we can face. Um, Also, I think it's important to consider specific challenges posed by respiratory pathogens, particularly their direct impact on our healthcare workers and their families. So unlike other health emergencies, respiratory pathogens really can quickly affect the healthcare systems that we require to respond to the crisis. So with these points in mind, I would like to open the floor for any questions or comments that participants may have. Feel free to, whether it's raise your hand or if you want to ask a question or make a comment or you have some contribution to this particular part of the discussion, you can put on your cameras and, we can start the discussion there.
Ornella, while people are thinking about their questions and comments, we would like to suggest that we take a group photo now that we have everybody now. So if you can,
if questions
Okay.
can be answered at the end, with the
Yes.
presentation, happy to answer or follow up directly. Okay, thank you again, colleagues.
Thank you so much, Angel. Okay, so
So-
as Evelyn mentioned, maybe now that all of our participants are online, we were waiting for some persons to log in earlier. If you don't mind turning on your cameras so that we can take a quick screenshot of the participants here today.
Hi, good morning. So I'm going to take the picture right now. So please, everyone smile or put your best face. Okay, that's it. Thank you.
Thanks a lot, Natalia. If there are no burning questions right now for the clinical care component of today's session, I would like to hand you over to Evelyn to get into the public health and social measures components of today's discussion.
Well, thank you so much, Arnella and Angel. And obviously this session is very short for all of the nuances and little details that you will need to consider for drafting your plan. But the idea is to expose you into more detail into what the recommendations for PRED are, that you can put a face to who you could ask questions to about these topics. So without further ado, I'll start with the community protection, focusing on the public health and social measures. As we've shown you this before, for the community protection component to the upper right corner there are 4 subcomponents: infection prevention and control in community settings, and that's why we're discussing this today, because it's in the infection and prevention. And within here, PRED touches on governance and actually interventions in the community. Also risk communication and community engagement, which is a much bigger topic that requires a whole session, and so that will be the session for the 20th of May with a specialist, Tanya, our advisor. And the other aspect is point of entry and border health, where we sort of touched on last week with coordination. And so today we're gonna delve deeper into the infection and prevention with the public health social measures. So what are these? Just to all be on the same line. So WHO is defining it as non-pharmaceutical interventions that help reduce the risk and scale of infectious disease transmission by reducing exposure or making those exposures safer. During the COVID-19 pandemic, the language, a lot of it was NPI, non-pharmaceutical interventions, but we're really moving towards the language of public health and social measures to really encompass what we're trying to do. So this is about the public health. And for respiratory, so public health and social measures can be used for all infectious diseases, and they're used for Ebola, monkey, Mpox, so for respiratory pathogens, what was important to keep in mind is that we are trying to lower community transmission in a pandemic setting. Also, hospitalization rates and obviously deaths, with the objective to reduce pressure on healthcare systems. We're just trying to buy time as diagnostics, laboratory tests, antivirals, or vaccines are developed. And obviously, to implement other interventions that won't be addressed with medical countermeasures. So again, going back to this analysis, which we hope you see that it is useful to at least to guide where attention should be pointed at. So here are the 4 countries that nominated participants for these sessions, and for the community protection aspect, risk communication and community engagement was mentioned or in most of the plans in the region, but public health and social measures wasn't. And points of entry also wasn't really mentioned. So there's a really clear gap here that we need to address when we're updating our plan. And as I mentioned, first we need to think about the governance of these public health and social measures, because while the health sector has a critical role to play in all of the health emergencies and also non-health emergencies, it won't be able to manage complex crises alone. But we're definitely the ones that we can push the conversation forward. And an effective response requires a decision-making body that's represented by all relevant sectors and disciplines. What you will read in the PRED guidance as a whole of a government approach. And this authority will vary across the countries, and it mostly depends on the administrative structure and the legal framework that supports the cabinet meetings or the executive meetings at the highest level where the whole of government works together. But what we want to reinforce and for you to consider when drafting your plan is that while obviously the administrative structure will make those decisions, the whole of society input is required. So here to the right, you can see how can we gather this input during peacetime to make sure that we have that information available from the health sector to the whole of our government, as we will be requested for information on what are the interventions that the health sector recommend to deal with this operational stage of the pandemic. So to keep in mind for respiratory pathogens again, is that we need this pre-existing infrastructure. If we start building it at the time a pathogen is detected in another country, and we know that it could quickly come into our borders, there will be other actions to be taken at the time, and that decision making might not be the most representative or adequate possible. Regular risk assessments will be required. Pathogens, and especially respiratory pathogens and viruses, mutate very quickly, as we all experience. We know from last session that we were all involved in the COVID-19 response, so we know that regularly is needed. So that needs to be included in our plans. That curiosity is going to be needed, and from a technical perspective, reinforce that epidemiological investigations are useful at all stages, and that we have the tools to conduct those investigations, and that the public health social measures need to be weighted against the impact they will have on all of the other sectors. And lastly, it needs to be within the legal framework that exists in the country. So if we know that an intervention will be useful in our setting, this is during peacetime that we need to make sure that policy review that you would have to conduct for the coordination component, that you make sure that legal framework for the public health and social measures also exists. So there are guidance that there's the checklist for COVID, the checklist for PRED, and there's the guidance as well from WHO and PAHO on the list of potential interventions that you can implement. For this section, I wanted to focus on SARS-CoV-2, just because we all have that recent experience, and is when a lot of different public health measures were implemented. So we guide you through this example to make it more operational and easy to understand. Here on March 2023, not too long ago, the last interim guidance on how to adjust these public health and social measures in the context of COVID were published only 2 years ago. So this is a really good reference to consider when drafting your plan. What COVID showed us is that public health social measures were critical. We needed them. We knew that we could develop a vaccine. We didn't know how effective it was going to be and how long it was going to take. Unprecedented development of medical countermeasures, but public health social measures were critical. The key objectives were very clear, and as I mentioned before, transmission, mortality, and impact on health systems. And it also showed COVID that we needed to have considerations in how to adjust, because the epidemiological context continued to change, mainly because of immunity levels, as transmission spread, as variants emerge. So that idea that is cyclical and dynamic needs to be embedded in our national preparedness plan for respiratory pathogens. For that pathogen X, we don't know if it's going to be a coronavirus, an influenza, or another type. And also that it needs to be adjusted as data and evidence becomes available. So here's a list of the public health and social measures that were implemented in COVID or that are listed in our guidance at some point. And as you can see, some are interventions that could be implemented within the health sector independently early in the pandemic, early in the stages, and then it will be rolled out to the community as needed. And others really require that whole of government approach immediately, like international travel restrictions is not a decision that the health sector will take eventually. So just to let you know where that final guidance ended up after the experience as we were evolving with the COVID. So first here, there's a recommended matrix for assessing transmissibility, impact on morbidity, and also mortality, and impact on the health system. This might seem familiar to many of you who work in surveillance, because we're talking about the PHSM indicators and the parameters. What basically the guidance is mentioning here, and something that you can adapt for your plan, is you need to assess the intensity within of the disease and these different dimensions. And then from that, you will have a situational analysis. In this case, it's recommended, it was possible to do it quantitatively. For other pathogens early in the pandemic, we have guidance, and maybe we don't have enough evidence to do this quantitatively, but we can do it qualitatively. The idea is that there's something systematic, transparent, and useful that different geographic areas and different leadership can understand of what we're doing. And all of the situational analysis allowed us to develop levels, and it's level from 0 to 3. For the particular case of SARS-CoV-2, at the time that a lot of immunity had been developed. I have an example of situational level 1, where we have minimal transmission and we have basic ongoing public health and social measures needed. So here you can see that we have individual public health social measures. Contact tracing at this point is useful because there's minimal transmission, so we can do supported quarantines. We have considerations for schools. We have considerations for businesses, for domestic movement. So this is just a systematic way to think, okay, at this point, with minimal transmission, we don't need to be at the highest level of alert in all of the sectors. And it's important that we keep that gradual categories also to align with multi-hazard response plans that may be in place, but to make sure that other impact on livelihoods is well calibrated. Just because today we have very short time, I want to leave time for questions, is that these are just some recommendations that you will find in the PRED guidance that are specific for respiratory pathogens. Protocols, indoor air quality. If we cannot impact the entire whole of society, we can promote within our development of the plan. Can we look into the health sector facilities for that indoor air quality, and again, protect that workforce that is part of is the key for the response. How are we going to monitor? How are we going to assess those intended negative consequences? The procedures, how are we going to be rolled out? An important aspect for respiratory pathogens at the pandemic level is mass gathering events, how they're going to be modified or suspending depending on the levels of transmission, and what governance is there to do this at the local or more, because a national guidance can be available, but at the local level, who is there to implement these the suspensions when needed? Care homes for elderly or other places with infection prevention control, SOPs that we can also make sure that they have adapted to the latest, to our national preparedness plan. Practice that leadership and governance, because sometimes we know what to do, but not who is going to make the decision. And we know that the stakes are high during a pandemic with decisions that are going to affect entire sectors. So simulation exercises are important to include that leadership and say, well, according to governance, this is where you come in. This was a clear lesson learned in the Central America sub-region, where a lot of the municipalities were not directly explicitly named as the responsibles to make decisions, but they wanted to operationalize the interventions as they see fit. So there was a disconnect between the cabinet and the municipality, the more local level, where actually transmission was taking place. And during the interpandemic period, that fostering of partnerships, and this is to be included in your plan. How are those preparedness plans in childcare facilities or civil society organizations, faith-based organizations, or invite them to simulation exercises to see how they would be impacted by a hypothetical scenario. And as Angel mentioned, also during the outbreak, this is the civil society community will be affected every year. So this is where we can practice those partnerships. Key messages: public health and social measures in this round of updating our plans need to be explicitly mentioned. And public health social measures need to consider that emergency management, the policies that are behind it, and financing. identifying that evidence-informed measures, we can plan how in our country we're gonna go look for that guidance at the time that we need it. Obviously, we have PAHO always available. We have PAHO and WHO tools like Know the Knowledge Hub, which in the next session you'll see is a compendium of systematic reviews that are constantly reviewing the evidence for all pathogens, and they're available there for decision makers to use them when needed. And also disease modeling, partnerships with universities or within the departments of intelligence in our epidemic and intelligence in our ministries. We can say, okay, this is one of the possible public health social measures. What are we going to do, and what's available to evidence? We need to emphasize in the plan the importance of risk-benefit assessment, and as much as possible promote the use of indicators that would help that transparency and understanding and communication with the community. And again, just to in the coordination, as in the clinical component and the community protection, engaging the stakeholders during peacetime will definitely strengthen our preparedness levels. Here to the right, you see the pages in the technical document and the checklists that are relevant for community protection, public health social measures. And here you have the links to the resources where you'll find the bulk of guidance available. So I'll leave it at that, so we have some time for questions.
Thanks a lot, Evelyn, for that presentation. Again, very comprehensive. It touched on a lot of the critical points that we do need to take into consideration as we update this particular component of the National Pandemic Preparedness and Response Plans. It is definitely very crucial to focus on integrating the community level PHSM strategies, particularly in those rural and underserved areas. And as you just left off on that topic, it will be very important in order to do that to engage like the local stakeholders and make sure that they are involved in the process, because that tends to lead to more buy-in and compliance with the recommendations that we make if they feel like they are part of the process for coming up with these strategies. Another very critical topic that you would have touched on was the fact that most of the plans did not were not very proficient in addressing the area of like with the ports. And given the Caribbean's reliance on tourism and cross-border mobility, sorry, definitely need more robust protocols around the area of ports of entry. So I think maybe now we would like to open the floor to any questions or reflections that persons have for today's session. Feel free to ask about anything that you found particularly relevant to issues that you are seeing in country or issues that you have encountered in, I guess, starting the process of updating these plans, and anything that you might like any further clarification on.
So good afternoon. I am Phyllis Pinas from Suriname. I'm the head of the NIC. And I have a question, just something I'm sitting with. It's a bit a silly question, but I just want to ask it. So listen, like when there's during the COVID-19 pandemic, there were different stakeholders involved. So now we have to write this plan for like Suriname. And my question is like, will all the different stakeholders come together to be engaged to write the plan? Like for instance, I'm just saying like the focal point for clinical management, like the stakeholders within the rural areas, like the ones that are like more involved with immigrants. Also, you mentioned port health, like the focal point of port health for the lab. Will also the microbiologist be involved of the hospital lab? Like, I mean, like every stakeholder, like also this um just one more focal point I wanted to mention, like the focal point for risk management. Will like everyone come together to write a plan, or will it just be one person that will write a plan and that the rest have to like you should make the plan your own? So that's actually what I wanted to know.
Happy to comment on that. And then I think Cornelia could add something from the sub-regional perspective. Oh, Angel, do you want to comment? No? Okay. Just one experience from other countries implementing PRET that really reinforces the multisectorial approach. To make it feasible and viable, a small group of people, and it ends up being a couple of people actually writing the plan. What has worked in other countries, and maybe not as small as Caribbean countries, but a small country in Central America with is that they had a workshop. So there was the epidemiology department that led the drafting of the process together with the emergency management unit. So they joined forces, and those two people make sure that it was well aligned and that they make sense with the rest of the policy framework. Then they started when they went through the checklist, they would call in anybody that they saw it was relevant. So clinical services. This is the considerations, and these are the components. We get their feedback. This is what we did during COVID. What was integrated into policy, what was institutionalized, some reporting systems, some dashboards, etc. So what was left that was done that worked, and what worked and didn't stay, but we will have to redo in another pandemic. And that was and they did a lot of that multisectorial engagement with every sector. So it is and it was very fruitful, but it took time. And it requires someone to make sure that there was coherence with the conversation. So there was, so they used PRET systematically to make sure that they were asking the priority questions. Then they conducted 2 simulation exercises. One was more of a workshop to gather more ideas, and then the second simulation exercise was to test it, how we covered this topic. And that's how sectors that might not have been directly involved in the writing process got involved. So as an example, the Justice Department was called in for the last simulation exercise. That what are we gonna do when people break their quarantine orders or something? And then they jumped in there because it wasn't their input wasn't needed for the entire architecture, but it was important to finalize that section. So to conclude, it's very important that a multisectorial committee is developed. That's the first step. And that can be 5, 7 people. That's what we recommend. And within that group, probably for the writing process, 2 people will be designated, and they will have to make sure that they liaise with the other sectors. Juliana, do you want to comment?
Thank you. No, I just wanted, I think Angel, can I go on? Oh, thank you, Angel. No, because Philly is the coordinator of the National Influenza Center. I think one of the worries is the laboratory component from her side. But I just wanted to add to this everything that you comment that the laboratory component is discussed as well with the National Influenza Center, National Reference Laboratories. It's not something that the laboratory is not involved because, of course, the laboratory is the backbone of all of this. It's where the pathogen is detected. So it's a multi-sectoral, multi-institutional plan, just to add this because of the laboratory component. Over to Angel.
Thank you, Juliana. No, for the clinical care component actually it's a great question, Phyllis, because and needs to be really in the context of each country. But specifically for clinical care, it's necessary just to have a focal point at national level in these committees. But this focal point really need to establish networks, contacts at all levels of the health services and healthcare providers, because it's not only case management like clinicians, it's also health services, clinical lab as well, and all the aspects for IPC that, as you see, is not only for the care of patients, also for the public health associated measures as well that involves. That need to be really joined with a high level political representation, because as you remember, as you see all in the COVID, it was really managed at the presidential levels. And in case in the Caribbean, I think like specifically for this component, the CMOs are critical to really work in these aspects. Okay, over. Thank you.
Thanks a lot, Phyllis, for that question. It definitely was a very important question to ask because it really reinforced the need for that multi-sectoral collaboration for us to be able to flesh out all the components of these national pandemic preparedness and response plans. While sometimes, depending on the setup, whether it's in your Ministry of Health, who would be lead on this activity, depending on how many officers you might have available, it's not that it's going to be a one person writing the document. You might really just have one person coordinating all the activities, whether it's the workshops, meetings, focus groups. One person might be coordinating all those activities to be able to get the right persons in the room to answer the different questions that, like the PRET, the PRET checklist kind of pushes you to get the information for to be able to have a comprehensive plan. So one person might put the document together, but it definitely is an activity that requires information and participation from all, not just sectors, but all levels as well. We can't just include whether it's like directors or any case of the ministries like the CMOs, etc. It would not just be their collaboration. We would need, information, whether it's from doctors in the health facilities that are working on the ground, seeing what's happening, etc. So it is a all-encompassing activity, and maybe it might be one person writing it, but definitely not one person responsible for coming up with all the answers to the questions that are required to be answered. So again, thank you for that. If anyone else has any contribution, any question, you can raise your hand at this time. As Evelyn is mentioning in the chat, there is a generic terms of reference that is available to help countries, put together their multi-sectoral committees as part of the step 1 of the PRET initiative. So that is available to you as one of the resources that is offered by PRET. If there are no more questions or contributions, any, reflections that anyone would like to share, we would like to thank you for joining today's session. We hope that it answered some questions that you may have had and got your gears turning to start updating this particular component of your national pandemic preparedness and response plans. We hope to see you in the next session that we'll have next week. And also, don't worry, we will send an email that will have a link to the recording of this session if you'd like to revisit anything that would have been discussed. In addition, Angel would have shared the presentation, but in the email, we will share both presentations with you, so you'll have that as a reference as well, and information for follow-up sessions as they occur. So again, thank you very much, and I really hope that everyone has a great day ahead.
Thank you.
Thank you.